So the next person who's going to talk is Dr. Kaleb Yohay. He's an associate professor of neurology and pediatrics and is the director of the NYU NF Center, where he oversees the care of the majority of the patients at the center. He attended University of Vermont Medical School, did residency at Johns Hopkins, where he helped start their NF Center, and then worked at Weill Cornell, where he was the director of the NF Center there. He came to NYU in the fall of 2014. He's involved in clinical research, including drug trials for NF1, NF2, and schwannomatosis. Please welcome Dr. Yohay.
Hi, everybody. Thanks, Marissa, for your outstanding talk, and I really appreciate you coming and sharing some of your experiences. And I know it's been a real journey, and I'm proud of you, and thank you for being here today.
Thank you.
And I'm really glad everyone is here today. It's a great turnout, and I know it's a big deal to give up a Sunday, and I hope that you find this time well spent. Just a caveat about events like this: we can't cover everything about NF in one day, and so I hope that you think of this as part of an educational series. We do this every year, and every year we try to do something a little bit different and try to include different information so that it's not the same information every time. One of the things that we haven't done today is talk sort of about the basics of NF, and we're not really doing that today. We're sort of assuming a certain level of understanding of the basics of NF. So, but we will have time for questions, and Dr. Elkin, myself, Dr. Allen will be up here after Dr. Allen's talk to answer questions. So if things have come up that we haven't covered that you're interested in or would like to hear more about, we can certainly try to do that during that portion of the session. And also, please do fill out the evaluation forms so that we can get ideas from you about what you want to hear about and what things we could do a better job covering, and what things we could elaborate on more thoroughly. So we've heard a lot about advocacy and life experience with NF, and we've heard about the eye exam and ophthalmologic issues in NF. We're going to make a big jump to transition to the new guidelines that have just recently been published that basically cover how to follow adults with neurofibromatosis type 1. And, NF has been around for as long as human beings have been around. And sadly, this year is the first time we've ever had actual formal guidelines published for how to take care of adults with neurofibromatosis. Adults with NF, I think, historically have gotten a little bit of short shrift from the medical community, and a lot of focus on pediatrics and taking care of kids with NF, which is great. I'm a pediatric neurologist, so I can't argue with that. But at the same time, and as came up in the question session this morning, there's a lot that happens in the transition from childhood to adulthood. And for all of you who are parents here with kids with NF, those children will be adults at some point, and we need to take good care of them as well. And part of our job as healthcare providers is to guide you in that transition and to take care of people with NF across the age spectrum. And one of the really challenging things about NF is every age with NF is different. And so we're treating different things at different ages and focusing on different things at different times. So all that is to say, even if you are a parent that has a kid with NF, I hope that this information that I'm going to talk about is relevant to you. If not right now, then at least someday. So the guidelines that we have been working on for a while and just got published were put together because guidelines are useful in several ways. They describe what the appropriate care is for a particular disorder or disease based on what the best available scientific evidence is or consensus among experts. And one of the goals of that is to reduce the amount of variation from healthcare provider and healthcare institution to healthcare institution. And I think what a lot of you have experienced, I think, is a lot of variation in doctors' knowledge of NF, not just doctors, but healthcare providers' knowledge of NF, as well as the quality of care that people get at different places. And so by putting out practice guidelines, we hope to make that care more even across the world and across the US. We also want doctors to be referring people to NF centers and to practitioners who know a lot about NF, and so guidelines can help with that. It provides a focus for educating ourselves and educating other healthcare providers about NF, and it promotes the use of resources appropriately. So not scanning too much or not scanning enough or things like that. One of the things that also comes out of doing or putting together guidelines is we realize not just what we know, but also the incredible amount of things that we don't know. And, sadly, as we worked on the guidelines, I think it's quite clear that there's a lot more that we don't know than what we do know, which is a common theme of NF. So the goal of the guidelines is to increase consistency, provide guidance for caretakers, and identify areas that need additional study and research. And lastly, it's also to hopefully provide improved insurance coverage. I think a lot of people here probably have come across issues with getting the services that they need, and having guidelines can actually be really helpful for that, because it just puts it down on paper. People with NF need this. And we can use that to leverage what we already knew, but just because it's written down and published somewhere, that helps us get that coverage taken care of. So earlier this year, this is what was published, the Care of Adults with NF1, and it was published through the American College of Medical Genetics and Genomics. And basically, it was just a group of us who sought to determine the main issues affecting adults with NF, and then reviewing all of the literature that's out there to try to put together reasonable recommendations and try to prioritize those recommendations and reach some amount of consensus about which things we should focus on and what the actual recommendations are. The practice guideline covered several specific areas. It covered cancer and cancer risk in neurofibromatosis. It covers blood pressure management and diagnosis, as well as issues that can occur in people with NF with their blood vessels. It covers bone problems and bone health. It covers cutaneous neurofibromas and treatment of cutaneous neurofibromas. It discusses some of the neurocognitive and psychiatric issues seen in adults with NF. It covers pain, chronic pain, headaches, things like that we see in NF. And also there's a section on contraception, pregnancy, and assisted fertility. So one of the main sources of information that we used to cover or to basically review our understanding of cancer in NF and to develop new guidelines for screening patients for cancer a lot of the information comes from a study that was done in Finland. Finland has a very well-organized national healthcare system, and because of that, they're able to follow essentially every single person in the country in great detail with regards to their health care and diagnoses. There's 5.4 million people in Finland, and they identified 1,400 people that they could evaluate over that time period of 1987-2012, which totaled 20,000 patient years that they were able to look back through and identify incidents of cancer, and compared to the general population. And some of these numbers are concerning and raised a lot of concern within the NF community, because actually a lot of them were higher than we had previously thought, and definitely has made us rethink how we screen patients with NF1 for cancer. But basically, some of the take-home points are that the lifetime risk of cancer in people with NF is about twice that of the general population, so about 60% lifetime risk compared to 30%. And that most of that increased risk is seen because of increased risk of cancer in young adults. So young adults, particularly in their 20s and 30s, as well as cancer in kids, particularly brain tumors in kids. Most of the increased risk of true cancer in NF1 are from the brain tumors and from a particular type of tumor called a malignant peripheral nerve sheath tumor, which we'll talk more about in a minute. One of the other important and interesting pieces of information obtained from the study. So this is a plot of cancer rates in people without NF1 compared to people with NF1. The blue line is men, the yellow line is women. One of the things that we hadn't really known before and are really just starting to learn about in the past couple of years is that women with NF1 have higher rates of cancer and higher rates of significant progression of some of their tumors than men or boys do. We're not exactly sure why that is, but it's true for optic pathway tumors as well as the malignancies that we see in adults with NF. This chart basically shows the relative risk of cancer over time in people with NF, where 0 is no increased risk compared to the general population, and the number on the left side is how many times the risk of the general population, the risk of cancer is. And so again, you can see a difference between girls and boys or men and women. And you can also see how the risk compared to the general population is quite a bit higher when you are looking at younger people. And then by the time you get into older adulthood, that risk is the same as it is for the general population. So as I mentioned before, the malignant peripheral nerve sheath tumor is one of the biggest sources of cancer for people with NF, and it's part of what Marissa was talking about earlier for herself. By age 30, about 1 in 10 people with NF1 will have a malignant peripheral nerve sheath tumor. By age 50, that rate goes up just a little bit to about 12%, and then the lifetime risk is about 16%. So it's not a small amount. It's also not everybody, but it is something that we always are actively thinking about when we take care of adults with NF and are always actively screening for, because we don't want to miss early signs of a tumor. This is an example of such a tumor with areas of increased metabolic activity. This was a tumor before it became malignant and then after it became malignant, and it increased in size and in terms of its metabolic activity. It's a very aggressive kind of tumor. It's a type of sarcoma, which is probably a more familiar term. And the things that tip us off to worry about a sarcoma are new pain that you can't explain and that's significant enough to wake you up at night or keep you from doing things that you want to do, though not everyone has pain with it. Rapid growth of a pre-existing neurofibroma. So if someone has a plexiform neurofibroma and it's been stable for many years but then starts to grow quickly, that's something that we pay close attention to. And then we also pay attention to whether or not there's new neurologic symptoms. So if someone suddenly becomes weak in their arm or their leg, we worry about the possibility of a cancer. Some things can increase the risk for these tumors, including particular genetic mutations, which are pretty uncommon, but one in particular called a microdeletion, and also exposure to radiation. And it's one of the reasons that we're very sort of conscious about the amount of radiation we use both in adults and kids with NF, both in terms of treating tumors, but also in terms of x-rays and CAT scans and things like that, and prefer to use MRI, which does not use any radiation. We don't really yet know, and this is part of what we learned from doing this paper, is that we don't really yet know the best ways to follow these tumors, what the best type of scans are, whether we should be using whole body MRI, when we should be doing things like that. But we do know that we prefer MRI over CT because of the radiation, that we do know enough that it doesn't help really to scan. If somebody has a plexiform neurofibroma, it doesn't really help to scan it over and over and over again. It's really the symptoms that we need to pay attention to. But we have been learning that if someone has a plexiform neurofibroma, that there is a change either on scanning or by symptoms. Those are the ones that we need to pay attention to the most. And this was a patient of ours, for instance, that had a tumor that was very soft and not painful for many, many years. And then suddenly it didn't grow much in size. This is the tumor before and after, but it became very firm and very painful. And that was a sign for us to do a scan and showed a change from a benign tumor to a malignant tumor. One of the really important things about managing these tumors is that they are difficult to treat. And it's really important to go to doctors who are very familiar with these tumors and do a lot of care. And so that was one of the other findings of this paper, is that high volume centers probably do a better job of taking care of these patients with malignant peripheral nerve sheath tumors in places that don't treat very many. The best treatment we found is that surgery with clean margins is the best possible therapy. So if you can get all of the tumor out and get the tumor and a little bit of normal tissue around it out, that's the best chance of curing these tumors. And if the cancer has not spread, then sometimes using radiation or chemo after surgery can be helpful in keeping the tumor away. All right, one of the other really important things that we have been focusing on in recent years and in this recent guidelines is the fact that there's an increased risk of breast cancer in women with neurofibromatosis type 1. And this is something that really wasn't recognized until about 7 years ago. The increased risk of breast cancer is particularly important in women aged under 40, so basically in the 30 to 40 year range. The overall lifetime risk of breast cancer is about 8% of women with NF1 by age 50 and 26% by age 80. And by the time women with NF1 get to be age 70, their risk has become the same as the general population. We are finding that women with NF1 may not respond as well to the standard treatments as women without NF1. So that's something else that we are trying to attend to. In terms of relative risk compared to the general population, if you take all ages of women with NF1, there's a 3 times risk of breast cancer. But in that under age 40 group, that risk is 14 times as high. So that's significant, and it's significant enough to have changed our management of breast cancer screening in women with NF1. We now recommend breast cancer screening starting at age 30 with an annual mammogram, and to consider doing breast MRI in addition to mammogram starting at age 30 and all the way through age 50. We currently recommend doing annual mammograms and every other year doing a breast MRI with ultrasound as needed. Part of the complexity is that women with NF are more likely to have benign lumps in their breasts because of neurofibromas. And so differentiating between benign lumps and cancer is more difficult. And doing things like a self-exam is probably not as helpful because there's just more to find, and you can't differentiate between a benign neurofibroma and breast cancer. We are hopefully going to start a trial to try to figure out actually what the best modalities to screen for breast cancer are, but we don't really know that yet. And we're sort of guessing by doing mammogram and MRI that would be a good way to follow these patients. There are some other cancers that are associated with NF that we keep an eye out for and need to keep an eye out for in adults with NF1, including malignant brain tumors, a intestinal tumor called a gastrointestinal stromal tumor, thyroid cancer, and a very rare cancer called the histiocytoma. And there are also associations with pheochromocytomas, which are tumors on the adrenal gland, and a type of leukemia in kids called JMML. So when we are seeing adults with NF, we have to be thinking about all of these different types of tumors and the symptoms associated with it, and making decisions about additional scans that might be necessary to rule these out or to evaluate for them. Right now, however, there isn't any protocol for just generalized screening for everybody. We wait until there are specific symptoms. For instance, in this patient who had a tumor in the abdomen called a pheochromocytoma, this patient presented with hypertension, and it's one of the reasons that we are very careful and methodical about checking people's blood pressure. Blood pressure and other blood vessel abnormalities are pretty common in people with NF1, and you can have high blood pressure because of narrowing of the arteries to the kidneys or because of these rare tumors called pheochromocytomas. Pregnant women and with NF1 may have a higher risk for stroke during pregnancy, and so that's something else that we're trying to be more proactive about and potentially do some amount of workup prior to pregnancy. We can see abnormal blood vessel growths, such as in this patient who has what are called aneurysms, so dilatations or enlargements of the blood vessels that we can see in probably about 5% of people with NF. And these can cause problems because of either blood clots or bleeding. Another problem area that we identified in adults is bone health. So we found that 20 to 40% of adults with NF1 have significant osteoporosis, and almost everybody with NF1 has low vitamin D levels. We don't really know why. But in adults with NF, fractures occur more easily, about 5 times the risk of having a fracture in a grown-up with NF compared to the general population, especially after age 40. And so we think vitamin D supplementation starting in childhood is going to be very important to maintaining bone health and bone mineral density. Scoliosis, we commonly think of as a pediatric disease, but it turns out that adults with NF can get scoliosis throughout their lives. And so we recommend that adults with NF get scoliosis screening on a regular basis as well. We also want to, or we have recommended that people consider earlier screening for osteoporosis with particular scans called DEXA scans, even though there isn't good data yet to show exactly how important that is, but we think that it is probably important. The skin neurofibromas are a big problem with NF, and one that has a problem that has gotten until recently pretty well ignored by the medical community, in part because these tumors are not cancerous, they're not dangerous, but they do cause really significant skin cosmetic issues and social issues, and can be very isolating for people with significant cutaneous neurofibromas. There is no medical therapy that is available to treat these successfully, though surgery, electrodesiccation, and laser treatment can be helpful to some extent, though the outcomes vary a lot from person to person and are not uniformly good. Itching can be a really big problem in people with cutaneous neurofibromas and adults with neurofibromas. And we can see that hormonal changes, particularly during menopause and pregnancy, can stimulate the growth of skin neurofibromas. And we don't really know why that is, but we do tend to see more and more of the neurofibromas develop with age. And so when we see adults with NF, we are counseling them about that. I am hopeful that we'll have some medical therapies for cutaneous neurofibromas in the next couple of years, but we aren't there yet. Pain is also a big part of NF1 in adulthood. A significant number of people have chronic pain. We don't always know why people with NF1 have pain. It's not just from tumors pressing on nerves. There's more to it than just that, but we don't really know what percentage of the NF1 population has significant pain, which is kind of amazing that that data has not yet been developed. We do know that a lot of people with NF1 can develop a very unusual but distinct pain pattern in their hands and feet from little tiny tumors that are not neurofibromas called glomus tumors. These are not cancerous, but they can cause really bad pain And we've diagnosed quite a number of people with NF1 who have had years and years of hand pain and found these little tumors that we can then remove and reduce pain. We don't know what the best medications are for treating pain in NF, though we have a number of different drugs that we tend to use to try to treat pain primarily as neuropathic, meaning we focus on trying to treat pain as if it's being caused by irritation of the nerves. In our paper, we also reviewed what we know about pregnancy and contraception. There is data to suggest that particular types of oral contraceptives might stimulate neurofibroma growth, particularly oral contraceptives or depot types of contraceptives that contain high levels of progesterone. And so we have been recommending that adults with NF who are seeking contraception to basically speak with their gynecologist about using types of contraceptives that use lower levels of progesterone. So some of the oral contraceptives use mostly estrogen. We think those are more safe than the ones that are higher progesterone. And we definitely do not recommend the depot forms of progesterone, which result in very high levels of progesterone. Some work out of Boston has demonstrated that there's a risk of high blood pressure and stroke in women with NF, as well as some problems with infants who are born to women with NF1, particularly small infant size. One of the things that comes up fairly commonly for us is that some anesthesiologists are very reluctant to do epidural anesthesia for women with NF1 who are giving birth, in part because they're worried about tumors that might be in the back that they're unaware of, and they are concerned that they might cause nerve damage by doing an epidural. But we have, in reviewing the literature, it looks like that's an unnecessary concern, and women with NF1, for the most part, should be able to have epidural anesthesia without any problems. So I know that's a very broad overview and sort of a superficial look at a lot of these things, but I'm going to end it there. And if there are specific questions about any of these issues, we can address it during the Q&A session at the end. Thanks very much.